Ladies and gentlemen, put your hands together for Dr. Eva Purkey, and her talk is Making Stone Soup and Building Stronger Communities.
As you go up to the north end of Kingston, there's a little bungalow. When you walk in, there's the stairs that goes down to the basement on your right, and the stairs are lined with toys and shoes and the stuff of childhood. If you go up to your left, you walk into a small kitchen. On the right, there's a windowsill with a row of brightly colored plastic sippy cups, clean and ready for use. If you continue your path around the corner to the left, you walk into a small dining room, and then climbing over a piece of furniture, you come back to the living room at the front of the house. In one corner of the living room, there's a playpen with a happy 2-year-old babbling away. Above his head, there's a gold helium balloon suspended from the ceiling, which is a remnant of some recently passed holiday. In the other corner, there's a big widescreen TV playing loud, cheerful children's music. The floor is covered in toys. The furniture in the room has been arranged to make a sort of barricade. The kids can't access the stairs to the front door or the rest of the house without a good climb. And it is in this space that we meet with the family that we have come to see. Over the course of 3 separate meetings, about 5 hours in all, we learn a lot about this family. We meet Tim and Jenny, and we learn about their 3 kids. There's a 4-year-old who we don't meet because she's in school. There's the 2-year-old who participates in all of our meetings from the playpen in the corner. And there's a baby who is only 6 weeks old at our first meeting, who's asleep in a car seat. Everything Tim and Jenny do is for these 3 kids. We learn that Tim and Jenny have struggled with substance use in one way or another for their entire lives. Both of them have struggled with addictions of their own, although they have been in remission on opioid replacement therapy, or methadone, for 7 years, and they fiercely protect their sobriety. This choice they have made to step back from street drugs has come at a real cost. They've lost contact with friends who are still involved in street drug use. Jenny's mother died a number of years ago from the complications of alcohol use. Tim's parents both actively use fentanyl, and so can't provide the grandparent support that would be so helpful for a family with young kids. Tim has lost a couple of friends, 2 at least, in the last couple of years from opioid overdoses. We learn about the challenges of parenting in poverty. We learn about substandard housing. We learn about being called out by public health for co-sleeping with your kid when the reason you do this is because you're afraid that rats are going to crawl over her crib while she sleeps. We learn about how difficult it is to feed a family of 5 when there are cockroaches in the stove. We also learn about the healthcare system. All 3 of Tim and Jenny's kids were born on either side of the pandemic, 1 before and 2 actually during. And 2 of them were actually hospitalized for infection during the lockdown. We learn about racism in our healthcare system here in Kingston. We learn about how complicated the system is and how helpful it would be to have someone help you navigate your way through. We also learn about community safety. We learn about how the neighborhood that this family has moved to is safe, how the kids play outside, how the neighbors are friendly. We learn about the school readiness program that has been such a support for their young daughter. We learn about street mothers. We learn about the community center that provides respite for this family when they just need a break or material or emotional support. We learn about their resilience. We learn about the substantial obstacles that they have faced and those which they have overcome. And we learn about how parenting together makes them strong. I have been a family doctor for almost 20 years. For 10 of those, I've been an assistant professor here in the Department of Family Medicine at Queen's University. I came to the university from the community because I wanted to do research and policy work that affected the broad social determinants of health of the patients that I was seeing in the office every day. I'm also a teacher. I teach residents and medical students and other learners, and I'm a clinician. I deliver babies, and I provide primary care for people in our community. Family medicine is about preventative health. It's about diabetes and hypertension and prenatal care. But more than anything, it is about stories. Stories of people overcoming tremendous odds, like Tim and Jenny. Stories of people starting over again in new countries where they cannot speak the language or understand the culture. Stories of people with mental health and substance use disorders. Stories of people struggling with a diagnosis of cancer, or with a birth, or with the death of a loved one. As a keeper of these stories, patients sometimes bring me small gifts, sometimes honey or chocolate, pictures of their grandkids or their dog, or bits of art or tokens from back home. I've learned that these stories can be transformative. They have transformed me as a healthcare provider, as a parent, as a community member, and as a researcher. Stories take the big truths that are going on in society, increases in global migration, a housing crisis, an opioid epidemic, and they make them real. They turn them into concrete problems to which we can actually find solutions. And when they are used in research, stories can transform policy and practice to change the health of the communities in which we live. I'm going to tell you a story of a health intervention. I have two boys. One is almost 14 and one is 10. And when they were young, we had a book called Stone Soup. And some of you will be familiar with that story, which has been set in many different places and times. In our copy, 3 monks come to a village. The village gates are closed. The villagers are suspicious and they have cut themselves off from their neighbors. Maybe they have been hurt. Maybe they have experienced stigma or violence. Maybe a pandemic. We aren't really told. What we are told is that they are mistrustful and they have stopped reaching out to share. The monks enter the village through a small gate in the wall, and they proceed, for those who are familiar with the story, to make stone soup. They collect 3 stones, a pot and some water, and they set them up in the empty village square. Gradually, and with curiosity, the villagers start to come forward. They peer from their windows and from behind their doors. And as the story progresses, they bring the things that they have kept in their houses. They bring vegetables, spices, and other ingredients to contribute to the soup. By the time the story ends, they've brought bread, tables and chairs, paper lanterns, musical instruments, and shadow puppets. They have created a community. They have created a wonderful stone soup. But they have also created a wonderful celebration. They have entertained each other's children, and they have nourished each other's minds and bodies with skill. So here's my big idea for you tonight. I believe that universities and communities together can make stone soup. I believe that meaningful, engaged, community-led partnerships between universities and the communities they serve that are based on sharing stories, knowledge, and experiences can be transformative. And that together, universities and communities can create synergies which improve people's health in ways that neither could do alone. One of the tools we have to do this is called community-based participatory research. Community-based participatory research engages patients as equal partners in the research process to identify and ask questions, to collect information, and to think about ways to understand and to share the knowledge that is created. This type of research recognizes different ways of knowing, different tools, and a different laboratory. It identifies stories, art, and images as knowledge forms that are complementary to and as valid as numbers and graphs. It leverages the wisdom of communities and uses it to change policy and practice in meaningful ways. In a recent study, our community-based participatory research group, iCreate, went out into the community and interviewed families about what had helped them or made it more difficult for them to thrive. iCreate is a team made up of academic researchers and community researchers whose goal is to examine research questions that are most important to the Kingston community. The community researchers on the iCreate team come from a wide variety of backgrounds with a variety of lived experiences, and they have often acted as advocates or allies in the communities of which they are a part. They bring community expertise and lived experience expertise, and the academic researchers bring research and methods expertise, and together this creates a really strong research partnership. Supporting this team is an advisory board which is made up of municipal government, community members, and service organizations. And these organizations include organizations that provide care for Indigenous peoples, newcomers, francophones, people with intellectual or developmental disabilities, children in the welfare system, public health, and many others. This advisory board ensures that the research we do remains grounded in the issues that are most important to the community. And importantly, it also ensures that the language we use and the methods we choose are accessible and acceptable to even the most marginalized community members who would be traditionally least likely to engage in the research process. And because this advisory board is made up of people who are often leaders within their own organizations, they are able to take up the findings of our research and use them to actually shape the policy in our community and the way services are delivered. In a study called Engaging Families to Build Healthy Communities, the community researchers from the iCreate team went out and recruited families who had experienced real adversity, families with young children like Tim and Jenny. They used arts-based methods like visual timelines and qualitative methods like interviews and focus groups to paint a really comprehensive and complete picture of what had helped these families or made it more difficult for them and their children to thrive. Then they gave cameras to the families, and using another arts-based method called photo voice, they sent them out into the community and asked them to take pictures of the things that were most meaningful to them. So either things that were just very symbolic or things that had really helped them to do well over the last number of years. The families then brought those images back and were able to engage with the research team to talk about what these images meant to them and how they felt that their experience could inform the experience of others like them who had also experienced adversity in their communities. Together with families, the research team was able to identify 12 broad areas that need to change for families with young children who experience adversity in Kingston to really be able to thrive. These led to a number of policy recommendations, and this translation is still in process. But an example is the way that substance use services need to be able to change in order to provide care specifically for families with young children. We learned from the families in our study that sometimes when they needed to access substance use services, they didn't actually have access to childcare. So they had no one to look after their kids, and the substance use services that currently exist didn't feel like very safe spaces or welcoming spaces in which to bring their kids. And so they were left with this really difficult situation. Either they don't access the care they need, or what do they do with their kids? So some of them were actually putting their kids in a taxi with an unknown taxi driver and leaving them in the parking lot while they popped in to get their substance use treatment. This is obviously not an ideal scenario. And not only does it create a barrier to healthcare access, but it also is a missed opportunity to create spaces and services that would really enhance the well-being of these families and these young children. You see, the monks couldn't make stone soup alone. They had some expertise, probably some stories from other villages. And importantly, they were able to create a space in the village square that the villagers had lost the ability to see. Like them, the university also has resources. Even though times are tough, we have access to funding, we have person power, and we have experience asking and answering research questions using rigorous methods. But at the end of the day, what the monks had were 3 stones, a pot, and some water. It was the community that made the magic. It was the villagers who knew what their community members, what their neighbors liked to eat, what games the children liked to play. Like them, the families in our study know what helps their children to thrive and what gets in their way. They know how to create spaces that are safe and improve community safety. They also know what ingredients are necessary to create accessible, acceptable, equitable, healthy urban planning. And they know how to nourish the mutual aid relationships between neighbors that is so important in building community. So like the monks and the villagers, the university and the community can create stone soup. They can build bridges that create spaces for people to come together who never normally occupy the same space or get to listen to or to speak to each other in other circumstances. But in order to do this, both will need to change. Universities will need to change. We will need to learn how to create open, welcoming spaces for community members to come into. We will need to learn from the flexibility of our community partners who are able to respond nimbly and quickly to the problems of their constituents in ways that are often uncomfortable for academic researchers. We will need to break down administrative barriers within the university, barriers that prevent us from adequately compensating people for their time and expertise, barriers that prevent people from participating fully in the research process, and barriers that stop people from accessing the services, spaces, and resources of the university, which is ultimately a publicly funded institution that needs to be open to all. For sure, we will keep a lot of our traditional structures. We will keep our ethics boards. And we will keep decades of experience in rigorous methodology that has helped us to ask and answer research questions in reproducible, important ways. But we will also need to recognize that many of these traditional academic structures have been set up to ensure the status quo and to create spaces of exclusion for the many people who historically have not been part of our club. The community will also change in this process. Already, the community researchers in the iCreate team have gained skills in research that they didn't have before. They've gained confidence in public speaking and competence in asking and answering and communicating their message to a wide variety of audience. When community is given space to engage and to be listened to, they are remarkably generous with their time. They are able to identify the wicked problems that are most important to them and therefore need to be to us all. And they are also able to come up with novel solutions which are often not accessible to academic researchers because of our own lived experience. While these changes are taking place, something else is going to happen. Community-based participatory research is a rigorous methodology that gets at the creation of new knowledge, but it is also a health intervention. Just like access to food or to nourishment in the stone soup story is a social determinant of health, so is civic participation. By creating spaces where people can be agents, can have agency to improve their own lives and the lives of the people around them, we are having an impact on their physical, mental, and emotional well-being, on their health, in ways that are transformative, often in greater ways than I can do in my office or clinic. Just think about it for a second. Think about some of the big things that are going on in your community or in your world right now. Think about how hopeless and helpless they can sometimes make us feel, and that's appropriate. Think about the impact that that has on your physical, mental, and emotional well-being. Now think of the last time that you were involved in a project where you feel that you really made a difference to someone's life. Maybe it was someone in your family, maybe it was a small group in your community, or maybe it was a person who you will never meet who lives on the other side of the world. Think about what that does to your sense of self, to your sense of confidence and competence in the world, to your physical, mental, moral, social, and emotional well-being. In addition to creating new knowledge, this is something that community-based participatory research can do as well. At the end of the story of Stone Soup, the monks leave town. The village has rebuilt itself. This is where the analogy ends. I would propose to you that the monks don't leave town. If the monks represent the outsiders, the academic researchers, the proverbial distant people in the ivory tower who come down into the village square to create a space where the magic that already lives there can happen, then I would propose to you that they need to stay. We need to stay. We need to be excellent researchers, but we need to be good neighbors and good villagers too. What does that mean for us? Well, for us that means going back out to the north end, up Montreal Street to Tim and Jenny's little bungalow and to the houses of the other families in our study. It means creating spaces in many different town squares where we can share the photos and the words of our research participants so that you can hear firsthand from them, instead of through intermediaries like me, what is really important to them and what impacts them most in their communities. It means working with our advocates, with allies and community members to identify those novel solutions I was telling you about, and then to implement them in research projects, and using research, evaluate them to see what really does make a difference in the health and well-being of our community. But more than anything, it means reaching out our hands to our academic colleagues and to our community partners in Kingston, in Canada, or wherever in the world you do your research. Stepping out of the university, out of the hospital, and out of the clinic, and into the community where most sickness and health actually happens, and creating space in many different village squares where we can make stone soup.